And then the sort of degree of lateralization, left-sided chest pain, radiating to left-sided structures, um, I think pushes a little bit away from cardiac causes and GI causes, more towards pulmonary and chest wall anatomy. And then the exertional dyspnea kind of maps onto that initial impression well too. I think the key element that we're missing right now is time course, right? If we learn that she's been having symptoms for a few days, the differential is going to be very different than if she's having symptoms for a few weeks or longer. And then, of course, because it's so common to have kind of pulmonary complications of systemic diseases, whether in the form of inflammatory diseases causing hypercoagulability and thrombosis, whether it's sort of infectious or malignant metastases to the lungs and the pleura, or rib cage. I think it's really important to listen for, as well as proactively ask about very thorough set of review of systems to see if there's kind of a more distant origin of the current symptoms. But I think common things being common, she could absolutely have a sort of a viral syndrome with kind of inflammatory pleuritic or other complications. She could have pneumonia, as I think someone mentioned, or she could have just musculoskeletal um, inflammation or fracture or injury that is both causing this pain. And because we have to move our rib cage in order to breathe, experiencing shortness of breath because of that restriction. So those are my initial impressions, and excited to hear more.
Right. So a little bit of background on her history. So she's coming back, initially hospitalized at an outside hospital where she had drug reaction with eosinophilia and systemic symptoms. And this was due to being on sulfasalazine. So she had gone through the course, she had been admitted for all the systemic features plus rash and discharged after recovery. She had a 2 week systemic corticosteroid taper following that hospitalization. And now she presents about 2 3 weeks later, and now she's developing this chest pain, and she's having diaphoresis, she's having fatigue, progressive dyspnea on exertion, as described in the initial aliquot. She said that the chest pain was worse when supine, improved with leaning forward. Over the preceding 2 weeks, she also had some fevers. This rash started appearing again, and then also having lower extremity edema, for which then she sought treatment at the hospital. A little bit of more history. So, past medical history, she had the episode of DRESS several weeks ago. She also has history of psoriatic arthritis, medications, sulfasalazine, which was discontinued following the DRESS diagnosis, also on prednisone and intermittently taking NSAIDs. Nothing noted in the family history, social history, health related behaviors, no previous allergies noted. And I'll stop there for discussion.
Thanks, Ravi. Yeah, we got a lot more now, both everything Zaven was asking for, time course, as well as a bit of background history. Maybe I will talk a little bit about just the experience with dress itself, and then maybe Zaven, I'll leave to you just the baseline history of psoriatic arthritis way further in the background as factoring into her current presentation. So incredibly critical to know this woman was just hospitalized for drug reaction with eosinophilia and systemic symptoms, a hypersensitivity reaction that is type 4 and precipitated by drugs, in this case, the sulfasalazine, but common drugs that can happen with are seizure medications, allopurinol, antibiotics, a lot of medications we use a lot. Um, as the name would imply, results in a systemic syndrome where rash is usually predominant. Um, but one of the other mucocutaneous symptoms that I've learned about is like a lot of edema too. Like your face and your oral membranes can actually get quite puffy from the reaction as well. The systemic symptoms, of course, means there's organ manifestations, liver, kidney, but cardiopulmonary organs can be involved also. So you can have a pneumonitis from it. You can, I think, rarely get myocardial or pericardial inflammation from it. So it really can cause itis of almost all organs. So I think that'll be pertinent to think about because she's coming in now with this chest discomfort, having weaned down off her steroids, which are the treatment. Sometimes in refractory cases, you have to add other immunomodulating agents like cyclosporin. But the fact that she just had this profound hypersensitivity reaction, which can affect the whole body, including heart and lungs, in the context of coming down off her steroids, does make me want to sort of put what Zaven had generally put out there, right? Inflammation of sort of pleural or pericardial surfaces back on the list with potentially flare of this hypersensitivity syndrome as a driver now for her chest discomfort in particular. Particularly now that her rash is back also kind of makes you wonder about resurgence of the original syndrome with lower dose steroids. Zaven, you want to layer on anything about the dress itself or just the psoriatic arthritis, the primary indication for the sulfasalazine to begin with?
Yeah, that's a great kind of dichotomy to wonder whether this is related to the most recent complication of therapy or to the original condition we were treating. And I think we have to, for the reasons you stated, my mind is that this is the allergy and the eosinophils kind of causing problems because um, psoriatic arthritis, rheumatoid arthritis, these sort of autoimmune diseases that somebody might have. And I also at some point I think someone questioned whether the kind of original diagnosis was correct all along, right? Could she have a different inflammatory disorder that was mimicking, what we thought we were treating? And is that now flaring up because we've discontinued the drug that was treating it, right? The sulfasalazine. But I think what argues against that is that we replaced the sulfasalazine with a much more powerful anti-inflammatory, which is high doses of steroids, which we tapered appropriately to moderate doses and eventually got them off. But it wouldn't be the the most expected time, I guess, for you to just develop pleuritis or pericarditis related to that immune disorder, and especially with the rash coming back. So I'm really curious what the peak peripheral eosinophil level was then, what it is now. And yeah, I'm very much worried about pneumonitis, myocarditis related to the eosinophilic process like you were, Steph.
Right, moving on to the exam. Great discussion so far. So I'll put in the chat to help the scribers. So vital signs, temperature 100, pulse rate 120, respiratory rate 20, blood pressure 100 over 60, pulse ox on room air 86%. She's ill appearing, she's diaphoretic, she's got dyspnea at rest, and she was tachycardic with borderline hypotension. She had jugular venous distension to the mandible, distant heart sounds, bibasilar crackles on lungs, and bilateral pitting edema and a diffuse morbilliform rash, which she had previously, but it looked like there was a resurgence. The initial labs, white cell count 20.4, 10.5% eosinophils, 1.5% atypical lymphocytes, platelets 84, sodium 126, BUN 38, creatinine 1.76, AST 250, ALT 320. The index presentation, the AST ALT was much higher. Bilirubin was normal. And I'll stop there for discussion.
Thanks, Ravi. I'll react sort of to the vitals and exam stuff, and you can comment on anything in in the labs you like. And yeah, this I think that the patient's context and symptoms sounded very concerning, and the vitals and exam are very concerning. She's febrile. Um, Her hemodynamics are compromised with the low blood pressures, with high heart rate. She's hypoxemic. I think I might have heard Ravi correctly. It was 86% on room air. Um, and then she has physical exam findings of either decompensated heart failure or cardiac tamponade or both. And then yeah, we're seeing sort of a worsening of mucocutaneous inflammation and in the context, I'll just quickly sneak into the labs for a second of the persistent significant eosinophilia with an absolute count of 2,000. I think I would presume that this is the process driving our symptoms and concerning exam findings. Um, and I think I would be very quick to follow up this exam with point of care ultrasonography if possible or measuring a pulsus paradoxus if an ultrasound was not available, to see whether there's a significant diffusion that may need decompression in a time-sensitive manner. Um, and then I'll hand it over to Steph to kind of talk a little bit more about the labs and any other systemic therapies, Steph, that you might initiate, even while we're figuring things out.
Thanks, Evan. Yes, I think we really continue to see the signature of the systemic inflammation and injury in the labs also. Three things in the white blood cell count and differential are all typical for DRESS. First is just the elevated white count itself. Now that's partly because there's an excess of eosinophilias. The absolute count, 10% of 20,000, right, is 2,000 EO. So there's hypereosinophilia there. But just leukocytosis itself is a manifestation with the elevated EOs. And then atypical lymphocytosis is actually one more hematologic finding that can be seen with DRESS, just as a kind of reaction to what's going on. So really three key features in the the white count that fit well with that. Um, and the thrombocytopenia, now here's something I'll look to you guys. I don't directly associate that as an effect of DRESS. I don't know if it can kick off a immune-mediated consumptive process. So that's one thing that I'd have to sort of think about. Might always put it in its own problem list for now. And then in the labs, we're seeing the signature of what potential organ injury had been there. Ravi told us, luckily, the hepatocellular inflammation, the AST, ALT are better than they were before. We still have an elevated BUN and creatinine, and very valuable with that will be getting a UA to see sort of degree of pyuria, which is a feature of the renal injury, and DRESS is often an acute interstitial nephritis, so manifests as a sterile pyuria. You can have proteinuria as well. So I think not only knowing the trend of her creatinine, but seeing the trend of her urinalysis can be helpful to figure out if the kidney injury is on his way to getting better or worse compared to what it was before there. Just
Oh,
looking to see if anyone, yeah, I don't directly associate the low platelets with the syndrome, but that just may be a knowledge gap area.
oh, wonderful discussion. Great job, Stephanie, with that. You're right on the mark. I'm going to stop sharing for a second, show some images. I'm going to go back to back just to increase the pace because he started late. Give me a second.
Thanks, Ravi. While you're doing that, I'm also just wondering if you're able to share like the exact doses of steroids she was started on,
I
and
think it
then
was
what the
six. Oh, sorry. Oh, 60 milligrams
okay,
was what she was on. And I don't remember the taper. Um,
and then she's been off for a little
one
bit,
week. 1 week.
1 week. Okay, so pretty rapid taper, and then off for 1 week. Yeah.
Here's the X-ray. Any quick comment of?
Um, yeah, I mean she's in looks like she's in heart failure. She's got bilateral effusions. She's got diffuse, kind of more perihilar predominant, both interstitial prominence as well as kind of patchy airspace densities. Her heart shadow is enlarged, and that could be from ventriculomegaly, or a pericardial effusion or both. And again, that's where kind of further imaging would be important. Um, and there's yeah, I mean this could all be from just cardiogenic pulmonary thoracic edema, but can't rule out a concurrent inflammatory pulmonary process as well. Um, yeah,
Yeah. Yeah, right. Exactly what was described in the radiologist report. Here's the EKG.
Steph.
Yeah, but I think stands out very quickly the low voltages and that again raising concern for what's in the pericardial space right between the ECG leads and where the conduction is actually happening. So in addition to the low voltage, it looks like it is in sinus rhythm with upright P waves in lead 2 before every QRS. And
Yeah.
nothing
So,
else is really standing out other than the low voltages.
yeah. So right on the spot, right on the dot or mark, low voltage criteria.
Ravi, do you
And
mind scrolling up real quick?
oh, sure.
I'll also just say I do think there's some ST changes that
Mm,
are a little concerning to me. If you look closely at lead 2, there's ST depression. At lead 3, there's slight ST depression. AVF is kind of isoelectric, and then going to V1, V2. V2, there's ST depressions.
mm,
V3, there's slight ST depressions. V4 as well. V5, maybe I'm imagining, but the absolute scale of
mm,
the ST depressions is small.
Oh,
But
yeah.
when you compare it to the QRS amplitude, and if we assume again that there's either pericardial fluid or something else isolating the electricity getting to the skin, the same degree of ST depression or ST elevation is more meaningful if the QRSs are small. So it's sort of a proportional thing where there's basically some signs on this EKG that there may be a myocardial process as well, whether that's kind of ischemic or inflammatory, but there seems to be some injury occurrence in addition to the
mm.
globally diminished voltage.
Yeah, very good read. Because of the amplitude, very, very small, so sort of described as non-specific.
Yeah,
But
absolutely.
yeah, this is suspicions. You're right, should be there. And I have a echo. I'll just pause here if you want to comment.
Do you want me to comment, Steph?
Sure. I mean, I see the pericardial effusion. Now, what hemodynamic effect it's having, honestly, I think a little hard to say. It looks like we can still see the both chambers well, but I'll add to your expertise or defer to your expertise, Sabin.
Um, I don't know about expertise, but
Mhm.
Ravi, do you mind pointing kind of as we talk
Oh, sure.
to the to the anterior pericardial effusion outside of the RV? It's that black anechoic thing, and then the posterior pericardial effusion behind the LV there. Um, and otherwise, just not assuming too much about kind of people's level of experience with echoes. Let me just kind of describe some of the view and some of what we're seeing. So this is a parasternal long axis view, meaning that we're using the parasternal, I'm going to show it on myself, the parasternal acoustic window where the heart is sort of anteriorly close to the skin, just to the left of the sternum in the sort of fourth or fifth intercostal space, with the probe marker pointing at the right shoulder, essentially kind of cutting the left ventricle and some parts of the heart longitudinally, where the first structure you see at the top of the screen is the right ventricular outflow tract. Ravi, if you don't mind pointing to it. Um, a little above that, the RVOT, the black
Oh,
circle at
oh,
the top of the screen. Yep. And then to the southwest of that is the intraventricular septum. And then the left ventricle, right on the other side of that, the left ventricular lateral wall behind that. And then the structure you pointed out for a second was the LVOT and the aortic valve and the aortic outflow tract. And then right below that is the left atrium. And between the left atrium and left ventricle, of course, is the mitral valve. And the thing you're seeing moving most is the anterior leaflet of the mitral valve. which under normal circumstances, every time it opens in diastole, there should be such a flow of blood from the left atrium to the left ventricle that the anterior leaflet of the vent mitral valve is kicked all the way open and actually touches the intraventricular septum. That's sort of the closest that it gets to the intraventricular septum is called IPSS. Yeah, EPSS, endpoint
APS.
septal separation, and it's essentially a marker of like how much blood is coming into the LV with every diastole. Because guess what? What goes in must go out. And that how much blood goes into the LV is also representative of how much blood goes out of the LV with every stroke volume. So the EPSS essentially is a marker of stroke volume, marker of cardiac output, marker of ejection fraction, and it should be close to zero. Again, the mitral leaflet should be touching the septum with every opening. It's not even coming close. So that, in addition to just the visual appearance of the left ventricular kind of systolic function, how much it's squeezing, how much the walls are coming together, what the proportion is of the anechoic space within the LV at its smallest versus at its biggest kind of helps you to estimate the EF. And visually, I would estimate this EF to be like 10% or less. Just it's as bad as it gets. There's really bad, terrible left ventricular systolic dysfunction. In addition to the pericardial effusion. And Steph, to your question of whether the pericardial effusion seems to be hemodynamically significant, it's hard to tell. We're not seeing enough of the RV free wall to see it kind of inverting or bouncing in a different view. If you could see the right atrium, you could get potential a sense of that. So actually, a pulsus paradoxus would be helpful in this case as well, and probably easier than some of the more advanced kind of mitral inflow respiratory variation that you could do with an echo. But there's certainly LV failure, and part of the syndrome could be driven from that. And whether there's also intrapericardial hypertension, can't rule out based on this view, but possible.
And wonderful discussion. Let me go back to the whiteboard.
And I think knowing how bad the output is and the signs of clinical heart failure on her exam, just reframing some of the end organ dysfunction. Is it from kind of progressive, damage from the eosinophils itself? Or, right, is her creatinine worsening? Is her liver perfusion or sort of liver injury worsening because of sort of flow issues? So it just adds a whole dynamic because what's causing organ injury?
Wonderful discussion on the echo, especially. So there was a demonstration. So there was a mild pericardial effusion, so no tamponade, and there was severe biventricular systolic dysfunction with LVF about 10 to 15%, global hypokinesia, and this mild pericardial effusion. So the next workup was doing a cardiac catheterization, which the coronary arteries were clear, but they were elevated right and left-sided filling pressures. And this then spurred dobutamine-assisted diuresis of the patient to improve symptomatology. And this EF definitely was a marked deterioration from initial presentation. Although we didn't have an echo at that point, she didn't have these findings. Eventually, she did better. And I'll stop there for discussion for anything you think we should do. Where should we go next with this patient?
I think a big question that needs to be answered is, what has made her cardiac function so bad? She's gotten a coronary angiogram and there's no obstructions there. And we talked about how the eosinophils itself, can cause myocarditis. But we didn't hear on the echo, or at least on the description you gave, any of some of the like classic findings just for primary stress-induced cardiomyopathy. But is the critical illness itself kind of the cardiotoxic effect? Is it the eosinophils? What is sort of driving her decrease in her cardiac function, I think, is still left unanswered, even as we're giving her inotropic support and getting her euvolemic.
Yeah, I really want to blame the EOs here. I think just given that we know it's happening, And they absolutely could be just damaging her heart. I mean, time is myocardium, and the only way to kill myocardium is not through ischemia, right? And I think in this case, clearly the effects um, are are very significant. So I really want to try to stop the underlying process. I would be really itching to, if I may, give this person, 125 of methylpred, if not 500, and then to enlist, our subspecialty colleagues in allergy immunology, dermatology, just whoever has the most experience. With treating DRESS syndrome to consider, Steph, as you were mentioning, some of the other immunomodulatory uh, agents that in some cases are necessary to suppress the inflammatory response in DRESS and drug-induced hypersensitivity syndromes with this severity of kind of end organ involvement. So that's kind of where I'm in that like time-sensitive treatment mindset.
So absolutely wonderful. Yeah, immunomodulation is key here. I forgot to mention the biomarkers, but the troponin was very elevated, 6.81, the high sensitivity. BMP 5000, CRP was 80 and elevated. I don't have the ESR. And for this patient, yeah, high dose steroids was started, cyclosporin. With further studies, a cardiac MRI was obtained, and this showed diffuse myocardial edema with late gadolinium enhancement of the mid myocardium and subepicardium of the basal, lateral, septal, and inferior walls. So all the walls where you saw in the echo, which were barely functioning and barely contributing to pump function. And then the next step showed was a endomyocardial biopsy revealing dense eosinophilic infiltration with myocardial necrosis. And
Got it.
I'll stop there before revealing the final diagnosis.
Think you kind of told us the final diagnosis, Robbie,
Mhm.
and
Eosinophilic.
I just hope this patient kind of recovered both in a short term, and I'm really curious and hopeful like how her heart and other organ systems recovered in a more medium and long term, keeping my fingers crossed.
Wonderful. Yeah. So the name or the term, this term associated with DRESS is acute necrotizing eosinophilic myocarditis, or can be used the abbreviation ANEM, ANEM. So there was actually recovery, repeat echo after initiating the patient on steroids, cyclosporin. The echo showed recovery to 40%, but there was still mild global hypokinesis. So on discharge, she was prescribed prolonged course of steroids, cyclosporin, and optimized medical therapy for HFrEF. So what actually happened, I think Amory put in the chat, did this patient actually complete her course of steroids? She actually didn't. She actually went traveling somewhere and forgot to take her steroids. Like, oh, I feel better. I don't need to take my steroids. And then hence it rebounded. So if you have a patient that comes back, so there's always this tendency we tend to have. I've seen cases on VMR, or we've had morning report patient has stress and then they get better and they go home and then that's it. But you always have to have a high suspicion for patients that can come back, and this can happen weeks out, just like DRESS can happen about 2 to 3 weeks after a insinuating agent or medication. Even weeks after that, several weeks after that, you can have a recurrence of DRESS or DRESS plus. So if the patient comes back with heart failure, so this ANEM can happen, renal failure, like Steph had mentioned, or liver injury can happen. So various manifestations, or just a rebound in DRESS again with possible severity. And you always have to wonder if the steroids were inadequate or abruptly discontinued or tapered rapidly. So I think this was an interesting case. It's really important. With early immunosuppression, it saves, like Zavina mentioned, right? You save your myocardium. Early immunosuppression can save. Time is of the essence, and delayed recognition leads to reversible damage. The mortality rate is pretty high, 45%.
Wow.
And this is quite rare. So you really have to be I guess, have high suspicion for a reoccurrence if somebody comes, have all the information, and then initiate the immunosuppression abruptly, or immediately, to save the patient.
Great case, Ravi, and part of that, right? Part of diagnosis and diagnostic accuracy is, the patient understanding the diagnosis and next steps. And I think this case is such a good reminder of, yeah, just the value in educating what it means to have an immune reaction, the importance of the medications, even once feeling better. That's something I definitely, I think, have fallen short on before. And this case is a good reminder of how key that piece of our diagnostic journey is making sure the patient knows and understands everything.
Yeah, always feel grateful to be able to learn from patients that we don't meet in person. So thanks Ravi for bringing the case. I was trying to like scroll through the chat. Was anyone able to look up whether thrombocytopenia is sometimes part of the syndrome, or because I think in conditions like this, it really is important to try to, kind of apply the full extent of your illness script for the disease, and see if all the findings are explained by the leading diagnosis. I love how Steph kind of, you mentioned, I would want to list this as a separate problem for now until I'm able to find or read or learn that, yes, this is part of the same disease as well. Because otherwise, like, there's a million symptoms, exam abnormalities, lab abnormalities, right? Like, all of which you're essentially putting under DRESS syndrome. Like, the atypical lymphocytosis is very much part of this, right? The patient, I'm guessing, probably had some lymphadenopathy and some other things that you would just find if you were to scan or whatever. Like, what falls into this process, and what is maybe something else that you don't want to miss, or part of a separate process that might need a parallel or different treatment or evaluation or whatever. Um, yeah, I think this happens a lot with kind of multi-system diseases, where you want to make sure that all the abnormalities are explained by it, and that there's not a separate thing. So what did we find with the platelets?
Looks like some people are seeing there's some TMA association sometimes. And for me, Open Evidence pulled up a pediatric case series, but in which those patients, 10% had thrombocytopenia. So much less common CBC manifestation than the other three: white count, eosinophils, and atypical lymphocytosis.
Wow. Cool. All right. Thanks again, everybody, and Ravi. Hans, do you want to summarize anything that stood out most to you from the case?
Yes, we could just briefly, in a few minutes, summarize a few essential points of this case. We had a 37-year-old patient, female, with left-sided chest pain, and this directs us from it was a positional chest pain with leaning forward being worse, away from any GI or MI, myocardial infarction considerations, to something else like an inflammatory process, maybe even a process involving metastasis. A viral infection came to mind, a pneumonia that hasn't been treated to the very end, or some musculoskeletal problems. We found out that the patient had a past medical history of an autoimmune disease. She received certain medications in the past, and she also developed a rash. And this made us think about a drug-related problem. DRESS came up. This would be a type 4 immunoreaction, which involves the skin with a rash. Here it is the problem: is it the rash from the drug, or is it a resurgence of her psoriatic arthritis, and organ involvement. And possible drugs that came to mind were listed here are allopurinol, which is very well known, or certain antibiotics. The vitals, furthermore, showed that the patient was hemodynamically unstable with a blood pressure of 100/60, a heart rate of 120. So we saw signs and symptoms similar to what we would expect with stress. Then the labs eventually showed hypereosinophilia and a lymphocytosis. In addition, we had signs and symptoms of organ damage. A chest X-ray was performed, and it showed an enlarged or widened cardiac silhouette and a possibility of a pericardial effusion, which was later verified with an echo. The ECG showed ST changes, and that was a first indication of the myocardium possibly affected. And that was furthermore underlined by the echo, which showed that the first mitral leaflet did not touch the septum, which is a clear sign of left ventricular failure. And the patient was indeed found to be in heart failure with an ejection fraction of 10/15. And the cardiac biopsy eventually brought forth or corroborated our suspicion of an eosinophilic myocarditis, which was necrotizing. Thank you very much. It was a good learning experience.
That was an awesome summary, Hans. Thank you. Thanks again, Ravi. Thanks everybody for joining. Have a great day.
Bye, everyone. Take care.